This time, it's a topic which I think everyone had to be involved in, corticosteroids. I think it's very important to be aware how to use corticosteroids in uveitis, but also what to avoid if you use corticosteroids, and what is the alternative at what time. So I think listening to this very, very important webinar should help you tremendously. As always, you know that you should register. After registration, you will send an evaluation sheet, and if you send that back, you get CME points in between a week. Sorry, there was already. Okay, so I will moderate this, and I think we start with Jean Duchesne from Canada, topical and injected corticosteroids. So enjoy this webinar, please.
Hello, Manfred. Hello, everyone. So let me share my screen. So my presentation is topical and injected corticosteroid. When are they appropriate? When are they not? Learning objective. At the end of this session, participants will know when topical and periocular steroids should be used to treat uveitis or intraocular inflammation. There was a discussion many years ago at the International Uveitis Study Group about the term uveitis. So intraocular inflammations or uveitis. So what steroid-related complication limit the use of topical and periocular steroid for uveitis?
Jean, sorry to interrupt you, but you have to share your screen. We don't see your slides.
Oh, you don't see my slide? That's funny.
Can you try again?
Yeah, I'll try again. Let me go back to the webinar. Zoom webinar. Screen. New share. It says I'm sharing.
Yes.
So here. That's my presentation. You see it now, Manfred?
Yes, now we see that. Can you go back to your first slide, probably?
I'll go back to my first slide.
Yes,
so basically, topical and injected corticosteroid, when are they appropriate and when they are not? So at the end of this talk, people, the ophthalmologists, should know when topical steroid should be used and when they should not be used. What steroid-related complication limit the use of topical and the periocular corticosteroid, and also when patient benefit from additional systemic therapy for uveitis. So topical and injected corticosteroid are quite important in the treatment of uveitis. It's very important to have a rapid control of the intraocular inflammations to help prevent the complication of uveitis, like the posterior synechia, the uveitic macular edema, the cataract. Often, if you treat correctly the patient with uveitis, you will prevent the early onset of cataract. Of course, corticosteroids do cause posterior subcapsular cataract, but they can also prevent the early onset of cataract. And it's important to treat rapidly with topical and possible injected corticosteroid to prevent chronic inflammation. So for the anterior chamber inflammation, it's very important to treat with topical corticosteroid, and this is good for all non-infectious uveitis. When you think about uveitis, the most important questions that we should have is that uveitis an infectious uveitis or non-infectious uveitis? So here you see the cells in the anterior chamber, and there's a movement, a convection movement, and the cornea is 35 degrees, the iris is 37. So this is why we have this convection movement in the AC. And when you look at the cells in anterior uveitis, you should not only look at the number of the cells, but also the size of the cells and the movement of the cells. If the cells are not moving, then there's a lot of fibrin. That movement also explains why we have the KPs most of the time in the inferior triangle. So correct use of corticosteroid, topical and anterior uveitis will control the symptoms, the pain, the photophobia, will also reduce the complications like posterior synechia, cataract, and macular edema. So corticosteroid topical are used for anterior uveitis, like in this case with an hypopion. The injected, periodical injected corticosteroid or intraocular corticosteroid are used for posterior uveitis or CME-induced macular edema. There's a different strength of topical corticosteroid, the most potent one being the difluprednate, which has an activity of about 60. Some other like fluorometholone 40. However, they don't penetrate as well in the AC. Dexamethasone about 25, potency, loteprednol 25, prednisolone acetate, Predfort about 4. However, we use Predfort most of the time because there is a much better penetration in the aqueous humor of Predfort. As you can see here, this is the peak aqueous concentration, and the topical corticosteroid and the prednisolone acetate here does penetrate the best in the anterior chamber. And this is why we're using Predfort most of the time in anterior uveitis. So the topical corticosteroid in anterior uveitis are the first line of treatment. They are most commonly used in acute anterior non-granulomatous uveitis, like the HLA-B27 related uveitis, and the non-infectious anterior uveitis of all type, like the idiopathic uveitis, sarcoidosis, juvenile inflammatory arthritis, etc. Also in post-surgical inflammation and in inflammation following ocular injury, the topical traumatic uveitis. In fact, inflammation following ocular injury is quite common, and often it is quite severe and lasts a long time. So be very cautious when you start decreasing the corticosteroid in uveitis associated with ocular injury. So when are the topical steroid appropriate? Well, of course, when you have anterior segment inflammation, especially the non-infectious inflammation, like the severe acute anterior uveitis that is non-infectious, like in this particular picture here. Often you can use every hour in the acute inflammation. If the patient doesn't respond correctly, then I will go every half an hour. And in rare cases, you can use 1 drop every minute for 5 times at the beginning of each hour. This is for Predfort. If you use something more potent like Durezol, this is different. Infectious uveitis, you have to be very cautious with infectious uveitis. As I said, the most important questions you should ask yourself with uveitis, either the anterior uveitis or the posterior uveitis, is this an infectious uveitis? Often, corticosteroids are appropriate in infectious uveitis, but you should really know what you're doing. So antiviral, antifungal, antibiotics should be present also. And they should be used at a very reduced frequency with close follow-up of the patient. So topical steroid, when are they appropriate? So yeah, infectious disease, herpes simplex virus, varicella virus, CMV, retinitis virus, you could use them, but you have to be cautious. Initial treatment of CME with active uveitis, personally I like to use topical NSAID plus corticosteroid, but that has to be mild, like vision better than 20/40 and not chronic. Also, the topical steroids are an adjunct to systemic immunosuppressive therapy in chronic uveitis and oral corticosteroid treatment. Now, topical steroids do have a lot of adverse effects, like the systemic corticosteroid. This is why often we like to use immune type of treatment. So the use of topical steroid is limited by cataract formations, increase intraocular pressure, glaucoma, secondary infection, and delay healing. So when shall we not use topical corticosteroid? Well, if a patient is really developing a cataract with uncontrolled or chronic inflammation, then we should think of something else rather than topical corticosteroid. In some cases, it's appropriate to continue using the topical corticosteroid, but rarely I'll do it alone. I'll always use something else, like immunomodulatory therapy. Increase intraocular pressure on one or more drugs, topical drugs or systemic drugs, then I will suggest that either you switch to a very low potency corticosteroid or stop the corticosteroid. Of course, glaucoma plus uncontrolled or chronic inflammation, you should really then consider something else than corticosteroid, topical corticosteroid. Complication of uveitis cause you and cause the patient. Delaying systemic immunosuppressive therapy will come in the cost of managing complex cataract and glaucoma. So there's an increased cost of care and surgical care of complication related to topical corticosteroid or complicated uveitis. It does increase the burden of treatment for the patient and decrease the quality of life of the patient. So chronic anterior uveitis, delay presentation. So there will be a surgical complication with anterior uveitis, like posterior synechia, port dilatation, papillary membrane, iris fragility, floppy iris, and also the joy of operating on a white cataract. We also have to delay 3 months for surgery when there is a active uveitis. Rarely should we do surgery within 3 months. There must be very rare cases, like if the patient has also a lens-induced uveitis, then it might be appropriate. There's, of course, intraocular pressure issue and glaucoma. And if you don't see the back of the eye, there'll be undiagnosed epiretinal membrane and CME that sometimes need to be treated. Now, you have to be cautious with all corticosteroid in general, but topical steroid in particular, in uveitis of unknown etiology. And if the dilated examination of the posterior segment has not been done. Sometimes I do see patients sent to me for uncontrolled anterior uveitis. And in fact, we dilate the pupil, which haven't been done, and look at the back of the eye. And the diagnosis is made by looking at the back of the eye. So unknown etiology, of course, you have to do lab tests, just X-ray as needed. You have to complete the investigation, and you have to rule out the infectious causes of the anterior uveitis. Syphilis uveitis, always think about syphilis. Syphilis is still with us. In Montreal, myself, as an ophthalmologist, I will diagnose about 14 syphilis a year, syphilis that were unknown because of the presentation with uveitis, and sometimes with anterior uveitis. So think of syphilis all the time. Syphilis is like herpes simplex. It's a great imitator. Always have syphilis in the back of your mind. Symphyretinitis, we don't see that much anymore, but we, at least in Montreal, Toxoplasmosis retinochoroiditis. Always be wary of toxoplasmosis and corticosteroid use and toxoplasmosis. Acute retinal necrosis and other viral diseases. Intraocular tumor will respond to corticosteroid because corticosteroid are toxic to lymphocyte. They will also decrease the inflammation associated with ocular metastasis, melanoma, retinoblastoma, intraocular lymphoma. So it's not because your inflammation will go down that those diseases are not ruled out. So always think that that could be a masquerade syndrome that you see. I'll give you an example here of a patient that was sent to me, 68 years old, 4 months post-cataract surgery. and the doctor cannot taper off the topical steroid after surgery. 1+ cells in the EC, vision 20/30, dilated exam, capsular white capsule, culture done. It was an infectious uveitis. Always think about infection and uveitis. Now, herpetic keratitis and uveitis, when I have fellows, resident with me, I always tell them, if you have a funny corneal lesion, always take the corneal sensation before you put any drops in the eye of the patient. So always think about herpes simplex and anterior uveitis, and especially if there is a non-typical corneal lesion. Of course, this one is very typical here. This is herpes simplex. So herpes simplex can be associated with keratitis, conjunctivitis, scleritis. Make sure that there's no history. And if there is an active corneal infection, you need to have oral antiviral. When shall we not use corticosteroid? Well, they're not very useful in intermediate and posterior uveitis. They're an adjunct to treat the anterior part of the inflammation, but they're not the mainstay of treatment. Macular edema, topical corticosteroids are not that useful. They are an adjunct also. And especially if you have a significant vision loss, less than 20/40, and a duration more than 1 month, don't try to treat that with just topical corticosteroid. Now, risk factor associated with cataract, recurring surgery, and uveitis associated with juvenile inflammatory inflammation, juvenile inflammatory arthritis. So 52 patients associated uveitis. Posterior synechia at presentation was the only significant risk factor of development of cataract needing surgery. There's no difference in the risk of cataract in those treated with periodical steroid or not. However, children treated with methotrexate do better as far as cataract presentation and the treatment of the cataract following surgery. Now, Durezol is a very good, potent corticosteroid, but it's dangerous. I'm very worried when Durezol is being started by somebody else in our hospital, and then they delay to send me the patients. I often will see very high increase in intraocular pressure, like 30 or even over. But it's a very good medication but you have to follow the patient carefully. It's an adjuvant again, and it does really help as an adjuvant to decrease the Cme. If you use that long term, you could end up needing glaucoma surgery in those patients. Cataract formation is also much more common with difluprednate, so be very cautious with the use of these potent topical corticosteroids. So, local injected corticosteroid, you could have periocular. Some people like to do it on the orbital floor. I don't. I like to do them partiosubtenon like this, and there's also intravitreal corticosteroid that you can use. The mechanism by which locally injected corticosteroid work is not very known. It does decrease the macrophage. However, after 30 days after a single subtenon injection of triamcinolone, corticosteroid is found in all the layers of the eye. The highest concentration being in the choroid and the retinal pigment epithelium. So this is the way I like. More often, my needle will be bent a little bit more toward the upper eyelid. So I like this partiosubtenon injection. Superior is very rapid. It's indicated in moderate to severe or recurrent uveitis, especially if there's no response to the drops after 5 to 7 days. It does help with Cme in moderate and severe chronic or vision threatening uveitis. It does help in pseudophakic patients with active inflammation. Now, when are periocular steroids useful? As an adjunct in the early phase of prednisone, by mouth, or immunosuppressive therapy, as an adjunct therapy for episodes of unilateral breakthrough inflammation while on systemic therapy, when the current health status of the patient dictate that prednisone cannot be safely used, or in diabetes with uncontrolled blood glucose and hypertension patients with renal disease, gastric ulcer, pregnancy. So they're useful as an adjunct. Can be repeated every 3 to 4 weeks. Myself, I like not to go less than 4 weeks of the periocular injection. The effect is relatively quick in 3-7 days. Most people will give a series of 3 if depending on the response of the inflammation. Myself, I'll go up to 5 injection at 1 month interval. So complication. If it is non-infectious uveitis, 73% of the eye will achieve a complete control of the inflammation. This is from this paper here, Periodical Corticosteroid injection in uveitis, published in Ophthalmology 2014. By 12 months, the cumulative incidence of 1 or more visits with intraocular pressure above 24 and 30 was 34% and 15%. So you really have to follow your patient closely when you do periocular corticosteroid. Cataract surgery was done within 12 months in about 14% of the patient. And obtaining the remission of inflammation was 69 to 76% after 6 months after the first injection. So eye with anterior uveitis were significantly more likely to gain no active inflammation using corticosteroid. Now, complication: ptosis, strabismus, temporary or permanent, orbital fat atrophy, orbital fat protrusion, and that is limited by the need for repeat injection. Now, intravitreal steroid injection, there's elevated intraocular pressure in 29 to 50% of the patient. Within 1 year, there is a 5-fold increase in rate of progression of cataract, and that increase with multiple injection. This is from this paper here, published by Tempest and Rowe in the British Medical Journal of Ophthalmology in 2013. Now, when shall not we use periocular or intravitreal corticosteroid? So when there's an active systemic disease, which should be treated with oral corticosteroid or immunosuppressive. This is an example of a patient with lupus, better treated with a systemic treatment. You have to be cautious again of infectious or non-infectious uveitis. For example, this is a case of infection. So you should not give periocular corticosteroid or intraocular corticosteroid in cases of infectious uveitis, post-infectious uveitis, especially toxoplasmosis, but also candida, acute retinal necrosis, and syphilis. There's some diseases that need systemic treatment. The most common one is Vkh disease, but serpiginous sympathetic ophthalmia, Vogt-Koenigsegg-Arada syndrome, necrotizing scleritis with systemic vasculitis. So usually when I see those type of diseases, I will rapidly start systemic therapy, especially with immunosuppressive medication. So in conclusion, when considering therapy for uveitis, you should know that the immune system is not a local phenomenon, and the target organ is not always the eye alone. So that gives you an overall idea of when to use and not to use corticosteroid. And be wary of complication of both topical and systemic corticosteroid. and especially make sure that you're not dealing with an infection, the uveitis associated with a infection etiology. Thank you so much.
Jean, thanks so much. That was very nice. Can we have can you switch off your screen?
Actually, it's I switch off. It's switch off. You still see my presentation?
No, we see you.
So
okay. Let's go to the gallery.
I'll stop the
Here
video
we go.
then. Okay.
No, Jean, we always love to see you. But then let's continue with Manisha. As a consequence, if you cannot use a topical, what about systemic corticosteroids? Manisha, we are listening to you.
Thank you, Dr. Manfred. Do you see my presentation?
Yes, we see that.
Yeah,
fine.
Thank you. So in the coming few minutes, I would be speaking on systemic corticosteroids, their role in uveitis. So this is a saying by Dr. Debra that no one is allowed to die or go blind without a trial of steroids. And that is very much valid to patients of uveitis. Eye diseases are among the most feared health conditions, and a survey showed that 60% of the people consider blindness as bad as death. Uveitis is a potentially sight-threatening disease, and it may occur due to infection or autoimmune etiology. The treatment of uveitis is evolving with newer drugs and innovative advances in ocular drug delivery systems. The treatment philosophy being that once you have ruled out the infection or malignancy, ocular inflammation is the principal cause of complications in most of the patients. And the control of inflammation is the primary goal. We have to do like a firefighting to control ocular inflammation. The other goals, of course, being an early control of inflammation with minimal side effects, prevent damage to the ocular structures, and prevent long-term visual loss in these patients. As far as the systemic therapy in uveitis is concerned, we have an induction phase, which is the initial phase of control of active inflammation applicable to all the cases of inflammation. And we have to do it as quickly as possible. As far as the phase of suppression is concerned, it is primarily applicable to chronic severe diseases requiring long-term suppressive therapy, and that probably is the key to the long-term success and good visual outcomes. As far as the systemic steroids are concerned, they are the first line of therapy in patients with non-infectious ocular inflammatory diseases. And why are they the preferred choice of drugs? Firstly, because they are inexpensive, they're very potent drugs, and they act very fast. Coming to the mechanism of action of systemic drugs, systemic corticosteroids, they primarily bind to the glucocorticoid receptors in the cytoplasm and exert effects on the DNA, which ultimately causes changes in cellular response. There are several other mechanisms of action of steroids which have been described, like anti-inflammatory and immunosuppressive effects, and they're involving several mechanisms, including they are causing an effect on several cytokines and additional signaling pathways associated with inflammation, vascular permeability, and leukostasis. They're all inhibited. It also tends to inhibit macrophage recruitment, migration, and antigen processing, thereby altering the cell-mediated immunity. It is also said to have some element of a bactericidal activity and also stabilizes the blood-retinal barrier. Now, coming to the indications of systemic steroids, the primary being chronic bilateral diseases beyond the anterior segment, which can well be taken care by topical steroids. Those cases which are resistant to local therapy, the eye diseases associated with any underlying systemic disease, and severe inflammation that is too painful or destructive for vision. As far as the relative contraindications to systemic steroids are concerned, we have diseases which are likely to be exacerbated by steroids, such as a patient who is a diabetic, hypertensive, or having any psychiatric problem. As far as ocular contraindications are concerned, a patient with a history of central serous choroidopathy, probably we would avoid systemic steroids. These, however, underlying comorbidities can be controlled in most of the instances. Coming to children, they're relatively contraindicated as they hamper growth. However, low-dose maintenance therapy may be used, but it needs a very close monitoring in young children. There are various preparations of steroids which are available. However, the most common which is used is prednisolone in the dosage of 5 milligrams, and it is said to be an intermediate acting. We do have forms of corticosteroids which may be short acting or long acting. For immediate control of vision-threatening diseases such as necrotizing scleritis, macular-threatening lesions, intravenous methylprednisolone sodium succinate can be used over a period of more than 30 minutes. It's usually given as a slow IV infusion. The usual regimen consists of 250 to 1 milligram per day intravenously on 3 consecutive days, like a pulse dose therapy. And it is also used when oral steroids, they fail to achieve the quiescence of ocular inflammation. Now, coming to the management approach, initially a high dose is used, which results in faster control of inflammation, and a similar amount of steroids given, then starting with a slower dose. The initiation of therapy is typically 0.5 to 1 milligram per kg body weight, followed by a slow taper once the inflammation is under control. Optimally, the dose should be less than 0.1 milligram per kg daily within 3 months of initiating the steroid therapy. As far as the induction is concerned, it usually starts with 1 mg per kg body weight of prednisolone. We need to reevaluate the patient in 1 to 2 weeks to see if the induction has been achieved, and add immunosuppressive therapy if the patient is not better in 2 weeks' time or the uveitis is still active on a follow-up at 1 month. We can also consider a pulse intravenous therapy for cases which are having a severe disease. Now, this is the usual routine, what we follow, and the tapering schedule that we follow with systemic steroids. So initial dose, we start at 1 mg, and then we usually taper it in the coming few weeks. It does require a very close monitoring, and we need to monitor the blood pressure, the weight of the patient, the blood glucose levels, and they need to be very strictly monitored at least once in 3 months. The lipid profile has to be monitored, and it is preferable to even monitor the bone density within the first 3 months and thereafter annually. Systemic corticosteroids, they would require a supplemental therapy in the form of calcium and vitamin D, and sometimes even the hormonal therapy is advocated. When we have a reactivation while we are doing the tapering of the corticosteroids, we need to observe carefully during the tapering for threshold, particularly near the threshold when we are reaching a dosage of 7.5 mg per day. If there's a mild reactivation, we can double the dose of prednisolone, but if there is a moderate or a severe reactivation, then probably it's better to return to 1 mg per kg body weight dosage as in the induction phase. Maintenance therapy for chronic diseases, long-term oral corticosteroids can be an option for severe diseases if the suppressive dose is 10 mg per day or less. A lower threshold is required if the patient is developing complications. And usually we would be opting for a dose of 7.5 mg per day or a lesser threshold. We can add immunosuppressive agents for steroid sparing if the suppressive dose is above 7.5 or 10 milligrams per day or is above the threshold of tolerability. Coming to oral corticosteroids in children, short-term steroids are acceptable, but the long-term steroids are contraindicated because they can hamper the growth in children. We opt for early use of immunosuppression while treating children. Growth monitoring is crucial in these young children, and generally such therapy would require a pediatric or a rheumatologist input. This is a whole list of various complications that we need to look out for while using systemic corticosteroids in our patients of uveitis. The various steps to prevent side effects would, of course, be the use of minimal effective dose, monitor blood pressure, blood sugar, and weight, and of course, supplement it with calcium and vitamin D. Now, coming to a few clinical cases of mine, like a 33-year-old young male patient having a history of trauma in the left eye with iron particle 8 days back, followed by diminution of vision, and underwent a corneal tear repair elsewhere. There was a diminution of vision in the right eye for last 1 day. The vision was 6/12 in the right eye, and in the left eye, it was hand movements. The right eye showed a reaction in the form of anterior chamber cells 1+. An IOFB removal was done in the left eye. And when we went ahead and did the fundus fluorescein angiography, we found these pinpoint leaks in the posterior pole of the right eye, which was very much suggestive of sympathetic ophthalmia. And this is how the OCT looked, where we had a huge pocket of subretinal fluid. The patient was started on intravenous methylprednisolone 1 gram per day for 3 days, followed by oral corticosteroids, and also the tablet azathioprine 2 milligrams per kg body weight was started. The patient at presentation was 6'12", which gradually improved to showed a gradual improvement in 2 weeks' time to 6'9", and at 1 month follow-up had improved to a 6'6" vision. This is another patient of mine, 61-year-old female patient, complaining of floaters and pain in the left eye for last 3 days. The vision in the right eye was 6'9" NH. She had a huge yellowish mass in the supranasal quadrant with exudative RD and dilated conjunctival vessels over it. You see the OCT, it is showing a lot of ripples in the RPE with pockets of subretinal fluid. This is the ultrasound picture, which was not very much informative. And when we did the fundus fluorescein angiography, we found a diffuse leakage in this area. The disc was, of course, a hot disc, which was suggestive of an inflammatory pathology. On doing the B scan, we apparently was not very sure. There was a very subtle T sign that we could make out. So the presumptive diagnosis was a nodular posterior scleritis with exudative retinal detachment. The patient was started on oral corticosteroids, 1 mg per kg body weight. And at 2 weeks follow-up, the patient did maintain a vision of 6'9" N6 with complete resolution of this lesion in the supranasal quadrant. This is another patient of a 24-year-old female patient with diminution of vision in the left eye for last 5 days, 2 months of ATT for pulmonary TB. Her Mantoux was strongly positive, and even CECT was suggestive of active Vkh disease. She had a huge granuloma in the supranasal quadrant, even involving the optic nerve head with cystoid macular edema in the macular area. And this is something we are following nowadays while we are treating these large TB granulomas. We evaluated the VEGF levels in these patients, which was as high as 927 picograms per ml. And we treat these patients now with intravitreal Avastin and moxifloxacin along with ATT and steroids. And you find there's an excellent regression of the entire TB granuloma. However, this patient developed a paradoxical reaction. You find a new lesion which has appeared, which is other than the initial TB granuloma. And this apparently was treated with intravenous methylprednisolone and stepping up of the oral steroids. At 2 weeks follow-up, we found that there was a beautiful regression of the entire TB choroidal granuloma, and the patient recovered a vision of 6'6" N6. In the current era of the biologics, are biologics really a replacement of steroids? Well, biologic therapy does provide a new option for the treatment of refractory uveitis, showing a favorable safety and efficacy profile, but probably the response is not as fast as steroids. There's, of course, a lack of evidence from randomized controlled studies, which limits the use of biologics in our patients. We are not very sure when to start the treatment, which drug to choose, and how long to continue the therapy. The high cost, the lack of long-term usage, and the reactivation of latent tuberculosis does limit the use of these biologics in a TB endemic country like ours. So the questions before starting steroids that we must keep in mind is when to give. We have to give steroids in the form of a systemic therapy when we are dealing with moderate to severe bilateral inflammation involving the posterior segment, when we find that the patients are resistant to local therapy, when the uveitis is threatening the macula and the vision, and there is an optic nerve involvement. What do we search for before we start steroids? Is there any systemic association, or is there any infectious etiology? And what to monitor? We must have a close monitoring of all the systemic side effects of the systemic therapy of corticosteroids. So the principles to remember for using systemic corticosteroids in uveitis would be assess the type of uveitis, rule out any infectious etiology or malignancy, which can be a masquerade, hit hard and hit fast. That means the induction has to be with full dose of systemic corticosteroids to control the inflammation as fast as possible. Maintenance with steroids or immunosuppressants, especially for chronic diseases. Use steroid judiciously with monitoring of all the systemic side effects that we are aware of. And early shift to immunosuppressants when we are using steroids in children. So thank you so much for your patient listening.
So Manisha, thanks very much. That was very nice. Good. So probably if you have questions, put them to the questions and answers. We will try to answer all these things. And we go on with Aniruddha Agarwal, how to use corticosteroids as bridging therapy. Aniruddha?
Hello, everyone. Greetings. My name is Aniruddha Agarwal, and I'm at Cleveland Clinic, Abu Dhabi. So I hope my slides are visible. I guess they are. Okay, so I'll be talking about how to use corticosteroids as bridge therapy in patients of uveitis. What are the indications, techniques, and outcomes? And I already see that there are some questions in the chat. So hopefully my presentation will be able to answer some of them. So we all know that inflammatory tissue damage is the hallmark of uveitis, and often patients lose vision because of cystoid macular edema. And also you have other manifestations such as increase in choroidal thickness, retinal vasculitis, and often retinal neovascularization. Now, there are a number of issues with systemic steroids, and so these patients may require extended therapy with systemic steroids. And systemic steroids and immunosuppressive agents can also cause reactivation of latent TB, which is a serious problem in endemic countries for TB, in addition to other side effects such as deranged metabolic profile, secondary infections, and abnormal blood counts. So in my practice, really, I do not use systemic steroids more than 60 milligram prednisolone per day. Studies have shown that more than 60 milligrams per day are not safe if used more than 2 weeks. So that's really the upper limit that I usually go by in my practice. And if I am pushed, I will go maximum to 70 milligrams per day. That's the maximum I have used. Now, the goal of treatment in uveitis, of course, we don't like vitritis or vitreous haze. And our goal always is to maintain patients on either 10 or less than 10 milligrams of oral prednisolone per day to avoid side effects of corticosteroids in the long term. Now, when you're using corticosteroids, it's very important to understand the pharmacokinetics and pharmacodynamics of both immunosuppressive agents as well as biological agents. So using corticosteroids like a bridge therapy, you can reduce the long-term adverse events related to corticosteroids. So let's talk about bridging with systemic steroids. The Visual 1 and Visual 2 trials of adalimumab have actually shown us the efficacy analysis in patients of uveitis, and all the patients in the Visual were initially bridged with 2 weeks of oral corticosteroids. And in all, there was a mandatory tapering of oral steroids, and the patients were successfully controlled with adalimumab, compared to the control population. So there are a number of treatment failures which happened, and that was the outcome measure in the Visual 1 and Visual 2. And the study showed that patients on adalimumab had a lower risk to fail with less criteria of treatment failure in both Visual 1 and 2. And this actually is very useful because it matches the real life scenario where we usually use corticosteroids for a short term and then switch to a longer lasting biologics or immunosuppressive therapies. Now, the Visual 3, in the Visual 3, the mean corticosteroid dose actually was quite low. It reduced to 2.6 milligrams per day at week 78. So in patients with active uveitis bridged with systemic steroids. So remember, it's very useful to bridge them with corticosteroids and then continue your biological therapy. And this will also reduce your systemic adverse events. So compared to methotrexate, azathioprine, and mycophenolate, remember, both infliximab and adalimumab have faster onset of action. So in fact, there's a question on the chat asking, would intravenous infliximab act as fast as methylprednisolone? Probably not so fast, but definitely faster to systemic immunosuppressives like methotrexate. Some studies have shown that adalimumab and infliximab may have onset of action within 2 weeks or as early as within 72 hours to 7 days of initiation of treatment. So if you are really pushed to treat with biological agents, then these drugs can be very fast acting compared to the traditional immunosuppressive agents. This is a 35-year-old lady with multiple lesions. This is a birdshot chorioretinopathy, and you can look at the fluorescein angiography with diffuse leakage and cystoid macular edema. Now, in this patient, the questions are, it's a bilateral vision-threatening disease. This patient has glaucoma with local therapy, and cyclosporin was not tolerated in initiation, and so of course needs a alternate therapy. Now, these are the situations where you need a bridge therapy. So when you're changing from one immunosuppressive agent to another, you need to bridge these patients with active inflammation with steroids for at least till the time your new immunosuppressive agent acts. And these patients may have visual loss because of macular edema, and therefore they will require treatment. Now, in this particular patient, you cannot bridge with local therapy because of glaucoma, so you have to rely on systemic treatment. So the practical considerations, like you have, this is the patient with baseline macular edema, and this is at 4 weeks, and at 16 weeks, you see the macular edema is responding. And this bridge therapy provides you adequate inflammation control till you have the immunosuppressive acting, and so it allows adequate optimization of the dose without exacerbation of inflammation. Of course, Vkh disease, a lot has been talked about Vkh, but not much on autofluorescence. And in fact, this manuscript by Dr. Rao shows that wide field autofluorescence showing you hypoautofluorescence spots in the retina actually indicate that the patients have been inadequately treated. So in conditions such as Vkh, any delay in therapy, even weeks after the initial onset, can cause permanent damage. And so you need to probably bridge them with treatments such as intravenous or systemic steroids. The other aspect is bridging with local corticosteroids. And of course, local corticosteroids could be used as adjuncts in choroiditis, could be used in cystoid macular edema, retinal vasculitis and vitritis, and panuveitis, of course, or if you have a suboptimal response to systemic steroids before or at the time of initiation of immunosuppressive agents, or if there is a contraindication to systemic treatment. And nowadays we have a lot of use of local therapies, but it's important to understand when not to use local therapy. So please do not use local corticosteroids when there is a diagnostic uncertainty, or if there is an infection where you're not sure that it's a toxoplasma or a viral lesion, and the results could be disastrous. So I also do not advocate local therapy if the media is not clear for any reason, whether it's a severe vitritis, there could be a retinitis lesion hiding somewhere, or if there is a dense cataract and there is no view. Also conditions such as exudative retinal detachments, choroidal detachments with low IOP, or of course ocular contraindications, please do not use local therapies. Now, local Ozurdex or an intravitreal implant of dexamethasone can be very easily used in patients of cystoid macular edema. So if you have an intermediate uveitis, the POINT trial has shown that intravitreal dexamethasone works as well as an intravitreal triamcinolone acetonide. I usually prefer Ozurdex because it's more predictable, less dosage, and the IOP response is more manageable. Finally, you can also use this. I'm completing with just a couple of examples here that you could use local therapies also in patients of vitritis, and also if you have a residual choroiditis lesion, you can of course use systemic local Ozurdex implant in these patients. And of course, TB uveitis is also something that can be treated with local therapy. This is my last case, and then I'll end. This is a patient who came to me with macular choroiditis, and this is a autoimmune condition with all tests negative for TB. And she was a heavy patient, 90 kilograms. So I hesitated in using systemic steroids more than 60 milligrams, but I gave her an intravitreal Ozurdex after ruling out all infections, including syphilis. And you can see that the lesions have responded beautifully. And at 4 weeks, she's completely off oral corticosteroids and the lesions have healed. So these are indications where you could use them as a bridge therapy. So just conclude here, the oral steroids are very safe if you use them for a short time as a bridge therapy. And local therapies are also a very useful bridge because it can improve outcomes and reduce systemic side effects. Thank you very much. I'll be happy to take any questions.
So Aniruddha, thanks very much for this very short, very clear presentation. And I think the next speaker will be Fernando Arevalo, and he will talk about intravitreal corticosteroids.
Thank you so much, Manfred. And I'd like to thank you and Vishali, Mark, and the International Uveitis Study Group for the kind invitation and the opportunity to speak about intravitreal corticosteroid therapy. There will be a little bit of overlap with the wonderful talks that we just heard, but this is always the key to learning. Let's see. These are my financial disclosures. And I'd like to acknowledge my co-author, Dr. Andres Lasave, my former fellow from Argentina. Systemic corticosteroids and immunosuppressive therapy are the mainstay to treat non-infectious posterior uveitis. However, we all know of the side effects associated with systemic administration, and that has prompted the adoption of local routes to directly deliver the drug to the site of inflammation. Local administration of corticosteroids is commonly indicated in patients with unilateral non-infectious posterior uveitis, not associated with systemic diseases. However, local therapy may also be a reasonable alternative in some specific cases of resistance, intolerance, or contraindications to systemic therapy. Corticosteroids administered locally include the triamcinolone acetonide injections, the dexamethasone implant, and the different options in terms of fluocinolone acetonide implants. So let's talk about triamcinolone acetonide. It has been for a long time the most commonly used corticosteroid for the treatment of unilateral refractory uveitic macular edema. You can see an example here from one of our studies that showed the macular edema resolution, and it seems to be very effective. And the main advantage of intravitreal triamcinolone is a very rapid delivery of a high concentration of this very potent corticosteroid to the posterior segment with very rapid effect. We published a series of cases at 24 months of follow-up comparing intravitreal bevacizumab and intravitreal triamcinolone for non-infectious uveitic cystoid macular edema. And we can see here that with both therapies, visual acuity improved, a little bit favoring triamcinolone acetonide. The central macular thickness decreased in both groups. And the big advantage of the therapy was that with triamcinolone, we had a reduced number of injections compared to intravitreal bevacizumab. However, the limited duration of effect of triamcinolone has resulted in a search for sustained release intravitreal implants, which have since become more frequently used alternatives. So let's talk about those sustained release intravitreal implants. And the development of sustained release corticosteroid implants have changed the management of non-infectious posterior uveitis in the past decade. Compared to periocular and intravitreal triamcinolone, they offer the advantage of a gradual and sustained release of the drug to the posterior segment, resulting in reduced rates of relapses and re-injections. Let's talk about the dexamethasone implant first. It is the 700 microgram insert or Osurdex. Is an intravitreal biodegradable implant approved for the treatment of macular edema secondary to non-infectious posterior uveitis. And it has about 12 times higher anti-inflammatory potency than triamcinolone. And due to its high solubility in water, it can achieve high concentration in the vitreous cavity. This is a study that led to the approval by the FDA. Here, eyes treated with 700 micrograms of dexamethasone as an implant showed a significant improvement in vitreous haze, best-corrected visual acuity, and central retinal thickness compared to sham. This is the design of the study comparing 700 micrograms to 350 micrograms of the dexamethasone implant, and sham, 229 patients were included here. And in patients with non-infectious intermediate and posterior uveitis, one injection of the implant significantly improved intraocular inflammation and visual acuity. That was for 6 months in the study. However, we know that in clinical practice, we usually have to re-inject our patients every 3 to 4 months. Again, of visual acuity, the big gainers, 15 letters or more from baseline, was seen in a significantly more number of eyes in the dexamethasone implant groups than the sham group. And the dexamethasone implant group had a significantly higher proportion of patients with absence of vitreous haze at 8 weeks, coinciding with the peak of dexamethasone vitreous concentration in pharmacokinetic studies. Here's from the study showing that the percentage of eyes with vitreous haze a score of 0 at week 8, with the implant much higher percentage of eyes than with sham. And this is the number of eyes with at least 15-letter increase in best corrected visual acuity through weeks 26. Again, much higher percentage of eyes with the implants compared to a sham. The percentage of eyes with IOP rise was about 7%, and compared to 4% for sham. And the incidence of cataract reported in phakic eyes was 15% with the dexamethasone implant, and 7% with sham. This is a graph that demonstrates the same data for IOP through the 26-week of a study. The percentage of eyes in the dexamethasone 700 microgram group requiring IOP lowering medications was about 23%. Annie alluded to this study, the POINT trial, that very nicely compared the effectiveness of 40 milligrams periocular triamcinolone to 4 milligrams of intravitreal triamcinolone and 0.7 milligrams of intravitreal dexamethasone implant to treat non-infectious posterior uveitic macular edema over a 6 months of follow-up. And central retinal thickness and best corrected visual acuity were significantly improved. Here we see in the graph, however, that the extent of central retinal thickness reduction and best corrected visual acuity gain were significantly higher in the intravitreal groups compared to periocular triamcinolone, and there was no significant difference between the intravitreal triamcinolone and the dexamethasone implant. So this study suggests that intravitreal treatment is superior to periocular approach in the management of uveitic cystoid macular edema, and that this efficacy between intravitreal treatments, namely triamcinolone and dexamethasone implant, is comparable. At the same time, the effectiveness of intravitreal corticosteroid implants in controlling intraocular inflammation has seen in cases of retinal vasculitis, not only macular edema. So let's turn to fluocinolone implants. This is despite the the short systemic half-life of fluocinolone acetonide, the advantage of this non-biodegradable fluocinolone acetonide implant is that it releases the steroid at a stable rate for up to 3 years, a much longer period of action than dexamethasone and triamcinolone, but it's used for different indications, as you will see. These are the fluocinolone implants that are available, the 0.59 milligrams or Retisert, the 0.18 milligram or Utic, approved by the FDA in the US for treatment of uveitis, and 0.19 milligram Iluvien, approved in the US for diabetic macular edema management, but there is very good experience in Europe for the management of uveitis with Iluvien as well. So this is the Retisert. It's an intravitreal implant, 0.59 milligrams of fluocinolone, was the first approved by the FDA for non-infectious posterior uveitis, and it's designed to release fluocinolone at a nominal initial rate of 0.6 micrograms per day, decreasing over the first month to a steady state between 0.3 and 0.4 micrograms per day over about 30 months. And this is a surgical video. I know this is a basic course and wanted to show for the trainees the surgical technique. It is sclerotomy is placed 3.5 millimeters posterior to the limbus, and the extension of the sclerotomy is also 3.5 millimeters. And then the sclerotomy is performed, and the implant is prepared with a Prolene suture, 8/0 suture. Usually, you can perform a limited vitrectomy externally, and you see the Prolene suture has been replaced on the stroud of the implant, and then the implant can be inserted and fixed to the sclera with a Prolene suture. And once it is fixed with that Prolene suture, I leave a little long the suture so that we close the wound with nylon 9/0, and that can trap that suture of Prolene to end the surgery. And you can see that here. Usually you need the Prolene suture in the center and then 2 more sutures to each side, and close the conjunctiva with Vicryl 7/0. Let's see, advance here. Several studies have shown significant improvement of visual acuity more than 3 years after implantation compared to pre-implantation at baseline in at least 20 to 30% of the patients. This is a very important study, the multicenter uveitis steroid treatment, the MOST trial, that compared the efficacy and safety of systemic corticosteroid plus immunosuppressants when they were indicated, and compared to the Fluocinolone implant Retisert. And in 479 eyes with non-infectious posterior uveitis, again, in this study followed for 2 years. And the study showed that both the implant and systemic groups showed improvement in intraocular inflammation, best corrected visual acuity, and control of macular edema at 24 months. There was no difference between groups. However, the control of inflammation at 24 months was more frequent in the implant-treated group than in systemic corticosteroids treated patients, and you can see the percentages there. The MOST trial published another paper on the follow-up at 70 years with 248 eyes that were enrolled. And over the 7-year follow-up, 94% of eyes resolved macular edema with a median time to resolution of 1 year, more than a year, while the cumulative proportion with relapse of macular edema was 43%. Compared to systemic corticosteroids, the hazard for relapse of macular edema was lower in the fluocinolone acetonide group with Retisert within 3 years of implantation, even though the difference was not statistically significant. However, it's important to mention that it was higher, however, with Retisert than systemic group after 3 years after implantation. So once the implant is depleted from fluocinolone, systemic therapy obviously is more effective. I think that if we can plan for reimplantation every 3 years of a new implant, or at least between 3 and 5 years, I think that in local therapy with Retisert is a good option in specific cases, of course. Eyes in the systemic treatment group with resolved macular edema required adjunctive short-acting regional corticosteroid injections at a significantly higher rate than the patients with the implant during long-term follow-up. So the group with systemic therapy was not only systemic, but had only the possibility of being treated with regional steroid injections as well. Since the Retisert implant requires surgical implantation with all the risks that are associated with surgery, new corticosteroids intravitreal implants have been introduced utilizing a simpler delivery method and overcoming these limitations. So namely, the idea is to do injections with fluocinolone acetonide, and the options are the injection of Iluvien or Utic that we already mentioned. They are intravitreally injected through the pars plana with a preloaded applicator with a 25 gauge needle in the office. Both are designed to release fluocinolone acetonide over a 3-year period at a rate of 0.2 micrograms per day, progressively decreasing to 0.1 micrograms per day. And this is, again, for the trainees, the way that injection is given. You take the cap and there's a thrombon that has to be taken out and keep the applicator vertical until you're going to inject and keep the needle in the eye for a couple of seconds to make sure the pellet goes into the eye. And this is very similar to the Ozurdex injection without the click, however. All right. This is a study that showed the 3-year results of the prospective randomized sham injection control clinical trial, analyzing the recurrence rate of uveitis in adults with non-infectious posterior uveitis treated with the fluocinolone acetonide injection compared to the standard of care. And here we can see that the recurrence rate of uveitis was statistically lower in the implant group compared to sham at 6, 12, and 36 months of follow-up. Here, over 36 months of treatment, the cumulative uveitis recurrences were significantly reduced with fluocinolone acetonide compared to sham. You see the difference there. In addition, a decrease in visual acuity from baseline was less common with the implant, and the increase in visual acuity, again, significant gainers, more than 15 letters from baseline, was significantly more frequently seen with the implant than with sham. The central subfield thickness decreased more in the fluocinolone acetonide group compared to sham. IOP was similar in both groups at month 36. The study demonstrated that 0.2 microgram per day intravitreal sustained release of fluocinolone acetonide is a safe and effective treatment for chronic and recurrent non-infectious posterior uveitis, being associated with a substantially lower recurrence rate and longer duration free time compared to the standard of care. In addition, the use of a lower dose of fluocinolone acetonide compared to the dose of Retisert of 0.59 milligrams allows a reduction in the risk of IOP elevation. Given the lack of comparative trials, we cannot say that these injections are better than Dexamethasone implant. And in fact, they are given for different indications. And it's important to stress that these implants have been licensed with for different conditions, especially with fluocinolone implant indicated with the objective of preventing relapses and not to treat active inflammation. So it's for a patient that you have little inflammation or inflammation is controlled and you want to avoid relapses. It's different from the Dexamethasone implant, which is a better choice when you have active inflammation. The longer anti-inflammatory effect of the low-dose fluocinolone implant compared to the Dexamethasone implant makes the fluocinolone acetonide more effective for the prevention of relapses. And finally, in probably a couple of minutes, I'd like to mention the suprachoroidal space with injections of triamcinolone. Is that the future? This is being approved recently as CyPair. More than 1,200 suprachoroidal injections have given in different clinical trials. And I wanted to show you this animation that shows the way the injection is given and how it is distributed circumferentially and posteriorly in the suprachoroidal space. And I also wanted to show you a video of one of the patients that was included in the clinical trial that led to the approval, again, by the FDA for uveitic macular edema. And these are the studies that were done to get the approval. In this study, it was performed to evaluate the safety and efficacy of the suprachoroidal triamcinolone in improving vision in patients with macular edema and non-infectious uveitis. And we can see how patients injected with the suprachoroidal triamcinolone had better visual acuity than control. And this is seen here with as well, the percentage of eyes with big gains in visual acuity was higher with the triamcinolone suprachoroidal injection. And the Peachtree study demonstrated 11% of patients with increasing IOP. This is another study that was performed to compare the results with and without concurrent systemic therapy. And again, these results showed an advantage of with the treatment with the suprachoroidal injection compared to control with or without systemic therapy. So I think this is a promising alternative. More studies are needed and comparison with the other options. Is this the future? We can discuss that in controversies later on. And finally, an invitation to our Pan American Congress of Ophthalmology, which will be occurring in March 2023 in Buenos Aires, Argentina. You're welcome to join us and contact me if you would like to participate. Thank you so much for the opportunity to speak.
Fernando, thanks very much for this very nice presentation. I've learned a lot. Well, to bring all these things together, we all hear about major positive work of steroids. I think it needs a good doctor, and probably you've heard with all these talks that there can be some faults, unfortunately. So I'm very happy that Zohar Habot-Vilner from Israel accepted our invitation to talk about what you have to know about corticosteroids when you order them. Zohar?
Hello, everyone. First, I would like to thank Vishali and Manfred for allowing me to participate in this lovely session. And my talk is on what you have to know about corticosteroids when you order them. I have no potential conflict of interest to report. Steroids are divided into corticosteroids and sex steroids. And corticosteroids are further subdivided into mineralocorticoid or glucocorticoid, which is being used in ophthalmology as systemic or local treatments. The treatment goals include fast resolution of ocular inflammation, prevention of complications related to the inflammatory process, and increased interval between possible relapses of the disease. Topical corticosteroids may be given as eye drops, and these include the 1% prednisolone acetate as Pred Forte suspension, the 0.1% dexamethasone sodium phosphate, the 0.1% dexamethasone alcohol, and the 0.05% difluprednate emulsion. In addition, we have some ointments, and these may include corticosteroid ointments alone or combinations of corticosteroids with antibiotics. Important to note that the efficacy of each preparation depends on drug's potency, the ocular penetration of the drug, and drug's concentration. In addition, dosing frequency also affects the efficacy. Suspensions have tendency to settle down to agglomerate and recrystallize over time and reduce dispersion homogeneity and allow potential dosing inconsistencies. So we need to ask our patients to shake well suspensions before applying this into the eye. In contrast, emulsions are homogeneous dispersions, and may have greater ocular bioavailability than suspensions. In addition, drugs with acetate preparations are more lipophilic than phosphate preparations and have greater corneal penetration. In this nice table, we see the combined index of various topical treatments. The combined index includes the relative concentration of the drug, the relative potency, and the transfromal corneal penetration of the drug. And we can see that dexamethasone and prednisolone preparations have much higher combined index as compared to fluoromethalone. And this is the reason that we should not offer our patients the use of fluoromethalone in uveitic eyes. A nice study compared between the use of Durezol to Pred Forte in eyes with anterior uveitis and showed that Durezol that was administered 4 times a day was at least as effective as Pred Forte that was given 8 times a day in resolving the inflammatory process. The authors concluded that Durezol provides effective treatment for anterior uveitis, however, it requires less frequent dosing than Pred Forte. The authors also showed that with Durezol, there may be higher complications rate, and the most common complication was intraocular pressure increase. So, when should we offer our patient topical corticosteroids? So the main indication is, of course, anterior uveitis, but we may also offer this treatment for cases with macular edema. Treatment should be commenced at high dose and tapered once the inflammation comes under control. We should give this treatment every 1 to 2 hours while the patient is awake for cases with moderate to severe inflammation, and I also ask my patients to use ointment at night. We should initiate a gradual taper over 1 to 2 months once the inflammatory settles down and is around +1 cells according to the Sun classification. Important to note that treatment efficacy is relied upon patient compliance, and inadequate dosing, rapid tapering, and either inadequate or no suspension shaking may lead to treatment failure. The aim of treatment is, of course, to bring to complete resolution of anterior uveitis or of macular edema with long-term minimal corticosteroids use and preferably no corticosteroid use. In cases of acute anterior uveitis, most of the cases will resolve nicely with no need for long treatment. However, chronic anterior uveitis is another story. And in cases of hepatic anterior uveitis, I ask my patients to use low-dose drops for a long time. Other chronic anterior uveitis should consider immunosuppressive treatment if there is a need for high-dose treatments. And in children, chronic anterior uveitis should be always treated as GIA-related uveitis. And according to the SHARE initiative guidelines, the accepted maintenance dose should be equal or less than 2 drops per day. In addition, systemic immunosuppression is recommended in cases if there is a need to use more than 3 corticosteroid drops per day for more than 3 months, or if the inflammation is reactivating during steroid dose reduction. In addition, we should consider immediate immunosuppressive treatment in cases with poor prognostic factors at first visit. Topical corticosteroids may have complications, and the risk increases with dose and duration of treatment. Elevated intraocular pressure may be found in 1/3 of the healthy eyes following daily use for several weeks, and this may, of course, cause glaucoma. Cataract may be seen as soon as 4 months after drug initiation. Other complications include increased susceptibility to infection or exacerbation of infections, impaired corneal wound healing, corneal epithelial toxicity, corneal or scleral thinning, and in children, they may have systemic absorption when they use high doses of corticosteroids for a long time. We should assess intraocular pressure weekly for the first 1 to 2 months of treatment, and of course, at each visit. And there are significant risk factors for intraocular pressure elevation, and this includes children, a history of primary open-angle glaucoma, and the concurrent use of systemic corticosteroids. However, ocular hypertension can usually be controlled and well controlled with topical medications, and in most of the cases, it will resolve several weeks after topical corticosteroids cessation. Regular follow-up to monitor response to treatment and the development of other side effects is very important, as they may develop several months following treatment initiation. Another treatment option is using the periocular or intravitreal corticosteroids, and they have some advantages as they provide local control of the inflammatory process. However, they avoid systemic side effects of systemic drug. In addition, the procedure is simple and could be repeated as needed. Periodical corticosteroids include posterior subtenon on orbital floor injections with the use of long-acting depot corticosteroids or subconjunctival injection with the use of short-acting corticosteroids. These treatments may be offered in cases of severe anterior uveitis if there is failure of topical treatment, as periocular corticosteroids achieve high concentrations of steroids in the anterior chamber and have a longer effect as compared to topical treatment. In addition, in cases of intermediate uveitis or macular edema or less common posterior uveitis, we may offer the patients to use posterior subtenon or orbital floor injections. And actually, both have similar effect. The treatment is very effective for cases of anterior uveitis, however, is less effective for macular edema and for posterior segment uveitis. We should not offer periocular corticosteroids in cases of necrotizing scleritis. However, few reports reported on the use of subconjunctival or subtenon injections for non-necrotizing, non-infectious scleritis and showed some good effect in some eyes. However, the effect may be transient and cause some side effects. Another treatment option is using the intravitreal corticosteroids, and this may be given as first-line treatment for unilateral intermediate or posterior uveitis and for unilateral macular edema. This treatment may be given for bilateral disease as supplement to systemic treatments, supplement to systemic corticosteroids in order to prevent increasing corticosteroids, or supplement to immunomodulatory treatment in order to prevent initiating corticosteroids. It also may be given as replacement treatment when systemic treatments are contraindicated. Disadvantages of these treatments include local adverse effects, which may be related to the injected drug, and eye injury and exacerbation of CSCR, and in rare instances, endophthalmitis. Contraindication for this treatment include ocular or periocular infections and glaucoma with uncontrolled intraocular pressure. The intravitreal triamcinolone acetonide may be used with Kenalog or Triessence, which is preservative-free. There is no consensus for dosing. Published study used the range of 2 to 8 milligrams, and 4 milligrams triamcinolone injections was found to be quite effective for macular edema resolution in up to 17% of cases, and treatment duration was effective for 3 to 5 months. Another option is using the intravitreal dexamethasone implant, and it is a very good option for eyes with vitritis and with macular edema. However, in up to 17% of the eyes, there may be a need for repeat injection in a median time of 5 to 10 months. It is also a good option for vitrectomized eyes and for children with posterior segment uveitis, and in cases of posterior uveitis as bridging treatment. Periocular and intravitreal injections share common complications. They may cause intraocular pressure elevations, a bit higher intraocular pressure elevations in the intravitreal group. They may also cause cataract development and the need for cataract operation, and the risk is higher with multiple injections. They are very uncommon to cause glaucoma or the need for glaucoma operation, and ptosis may be seen with periocular injections, and ophthalmitis is a rare complication of intravitreal treatments. The POINT trial was a multicenter randomized comparative trial, and it compared intravitreal treatments to periocular injections for the treatment of uveitic macular edema. And it showed superiority of both intravitreal triamcinolone acetonide and intravitreal dexamethasone implant for the treatment of macular edema as compared to periocular triamcinolone injection, with only modestly greater rates of mild intraocular pressure elevation for the intravitreal treatments. No significant differences were found in the use of intraocular pressure medications between two groups. Another option is using the Retisert, which is the surgically inserted fluocinolone acetonide implant with an action duration of 13 months. And it actually may serve as an alternative treatment to systemic immunotherapy. The MAST trial 7 years results show comparable results with systemic treatment up to 4.5 years, but thereafter better visual acuity outcomes with systemic treatment, which emphasizes the need to replace the Retisert implant in a timely fashion. Another option is using the Optic, which is a non-biodegradable injectable fluocinolone implant with action duration of 36 months. Using this option showed significant reduction in uveitis flare during 36 months, and in a third of the patients, they were free of uveitis recurrence during 36 months. Common complications are cataract, the need for cataract operation, the need for intraocular pressure lowering treatment, and glaucoma operation in both Retisert and Optic use, with higher incidence for these complications with the use of Retisert. And last option is using systemic corticosteroids. There are several indications for this treatment, and these include severe anterior uveitis cases in which other treatments failed, bilateral posterior segment uveitis, bilateral macular edema, uveitis associated with systemic inflammation, and if there is contraindication for the use of periocular or intravitreal corticosteroids. The most common used drug is oral prednisone, and in severe inflammation, we may offer our patients the use of intravenous methylprednisolone for 3 days. Most important is to discuss and explain our patients the aim of treatment, to discuss possible side effects, and to rule out infectious causes of uveitis, such as TB and syphilis. The recommended initial dose is 1 milligram per kilo per day, with the maximum dose of 60 to 80 milligram per day, and slow tapering once the inflammation is under control, with a maintenance dose of equal or less of 7.5 milligram per day. The tapering schedule is according to the dose, and the treatment is decreased every 1 to 4 weeks. Important to note that short-term treatment up to 3 weeks, even if at high dose, can simply be stopped with no need to treatment tapering. Testing for the HPA axis function is appropriate when patients are using equal or less than 5 milligram per day prednisone, and if there is difficulty to reduce this dose further because of systemic symptoms. Important is to monitor blood pressure, electrolytes, fasting glucose level, complete blood count and weight at the baseline and weekly for the first 2 weeks of treatment and every 4 to 6 weeks thereafter. Regarding diet, it is very important to avoid salty and high sugar foods, and we should recommend our patient to use proton pump inhibitors, especially if there are risk factors for peptic ulcer disease, as the use of concomitant NSAIDs and in elderly patients. Patients that use long-term corticosteroids need to have bone density test, and this should be done within the first 3 months and annually thereafter. We also should ask our patient to use calcium and vitamin D on a daily use, and for the prevention of osteoporosis, we should advise them to have regular exercise, to have adequate dietary calcium intake, to avoid smoking, to limit alcohol consumption. And regarding the use of amino biphosphonates, I refer my patients to endocrinologists. We should consider prompt initiation of a non-corticosteroid immunosuppressive treatment if there is an inadequate response after several weeks of high-dose treatment, if there is ocular disease known to have poor prognosis with corticosteroids alone, or if the patients are unable to use corticosteroids due to side effects. We should always remember that prolonged systemic corticosteroids should be avoided in children who may experience growth retardation. Regarding side effects, the risk for side effect is dose and duration dependent, and there are various side effects that may harm any organ in the body. Regarding ocular side effects, cataract will develop with prolonged systemic use. In most of the cases, the cataract is bilateral and develops slowly. Regarding glaucoma, this may be seen after 2 weeks of systemic treatment, and with topical treatment, there is a higher chance for developing glaucoma as compared to systemic treatment, and primary open-angle glaucoma is a high risk for glaucoma development. The MASS trial looked on the quality of life and risk associated with systemic anti-inflammatory therapy versus the registered treatment, and showed that ocular complications occurred significantly more often in the implant group. However, systemic complications were only slightly higher in the systemic treatment group, and there were no difference between groups at 54 months. So, judicious use of systemic corticosteroids is a reasonable, safe practice. What about drug interactions with systemic corticosteroids? Important to note that antimicrobials, as rifampin and rifabutin, may decrease the effect of corticosteroids. On the other hand, the use of estrogens and immunosuppressants as cyclosporin and tacrolimus may increase the effect of glucocorticosteroid. In addition, glucocorticosteroid may increase anticoagulant effect of warfarin and may potentiate potassium wasting effect of diuretics. In addition, they may cause glucose dysregulation in diabetes patients and may increase risk of peptic ulcer disease in patients using NSAIDs. So, in summary, corticosteroids may provide an excellent first-line treatment choice for patients with ocular inflammatory disease. The availability of various preparations and modes of administrations allow for great therapeutic flexibility. Judicious use of corticosteroids is a reasonably safe practice, and side effects should be monitored and treated appropriately. I thank you very much for listening.
Well, thanks very much. This was a wonderful conclusion of all the other talks, with putting the emphasis for the practitioner. It's a fantastic drug, but please be aware that you are working with a difficult drug which needs some aspects. So, Alexandra, your turn, I think. And
yes.
You will talk, Alexandra Rodosavljevic, top 10 faults in the treatment with chronic corticosteroids.
Yes, thank you. I would like to thank Professor Tierhut for this very kind invitation and great honor to participate in this lecture. I will try to concentrate on top 10 faults in the treatment with corticosteroids, but also options how to avoid them. And I will try to give some examples to our younger doctors and help them avoid all those problems. So corticosteroids represent the mainstream of therapy of non-infectious uveitis due to their potent anti-inflammatory and immunosuppressive effects. The treatment with corticosteroids, both local and systemic, should be done with special care since they can cause many important side effects. The side effects usually depend on the dose and duration of corticosteroid treatment. However, some can occur in predisposed persons anytime, so quite early. So the most common ocular side effects, as we know and are mentioned, are cataract, which also usually occurs after longer treatment, then secondary glaucoma and central serous chorioretinopathy, which can occur anytime. However, we must be cautious because corticosteroids can cause reactivation of infection due to suppression of immune mechanism in the eye, or atypical or very severe spread of infection in newly infected persons. So I would like to show a few cases to just emphasize those points. So this is a patient treated for 5 days with pulse intravenous corticosteroids for papillary edema in the left eye. After the treatment, left eye edema resolved, visual acuity improved, but lost vision or decreased vision in the right eye. After scanning, we realized it was acute central serous chorioretinopathy. Acute central serous chorioretinopathy can occur also after longer treatment, and this is a patient with retinal vasculitis, periphleboitis, and intermediate uveitis treated with peroral taper of corticosteroids for 6 weeks, after which he developed acute central serous chorioretinopathy, which was seen on fluorescein angiography and OCT. The systemic side effects of corticosteroids are multiple and include the onset of diabetes, especially in pre-diabetic persons, which are not followed enough, hypertensive crisis, especially in patients who already have hypertension, osteoporosis, especially elder female patients, and with chronic usage, of course, osteoporosis, obesity, Cushing syndrome, adrenal suppression, but mood changes, which can occur especially in the patients with the pre-existing psychiatric conditions, and sterile necrosis of the hip. The last two can occur anytime, so early or later in the treatment. So the main faults with systemic corticosteroid treatment include faults with diagnostics and faults with treatment. Regarding the faults with diagnostics, the first and the most important one already mentioned is not investigating all the infectious causes. So missing infection is the major problem. Then other are giving corticosteroids before the diagnostic immunological assays because it would mask the results. Then giving systemic steroids as first-line medications without assessing the patient with fluorescein angiography and other diagnostic procedures. Then not considering atypical causes of uveitis like masquerade syndromes. Faults with treatment include not taking into consideration patient's systemic condition, not considering interactions with other medications, giving systemic corticosteroids for chronic autoimmune conditions for too long, and not giving steroids aggressively enough as a first-line treatment for vision-threatening non-infectious uveitis. So not too long, but also not miss when needed. So the first point, giving corticosteroids as a first-line systemic medication for uveitis or scleritis, but without investigating or covering for primary potential infection causes can be detrimental for the eye. The most important are viral causes like HIV or herpetic retinitis, or syphilis or Lyme disease or fungal infections. Corticosteroids may be given by mistakes in those cases and could cause major damage to the eye. If the patient is covered for primary infectious cause, usually systemic corticosteroids may be introduced after 24 or 48 hours. So this is a patient who was referred to us after 1 month treatment with the peroral prednisone. The patient also during this treatment developed retinal tear and retinal detachment, and he was very thoroughly investigated. However, only one test was missing, and that was test for syphilis. So venereal disease research laboratory test was positive, and ocular syphilis was diagnosed, and patient was then treated accordingly. This is a second patient which lost vision in one eye, left eye, due to uveitis and retinal detachment 7 years ago. Was referred after treatment for anterior uveitis with the large keratic precipitates, pigmented, and also vitritis. Also, they saw edematous optic nerve and gave 1 dose of systemic corticosteroids. However, when the patient was referred, and they also noticed when they managed to see the periphery of the fundus that there was actual retinal necrosis, acute retinal necrosis in the periphery, and patient was referred to us. So this dose of systemic corticosteroids could be detrimental, but however, we managed to save the patient's vision so far. This is one very severe case of a patient which was hospitalized at the Clinic for Infectious Diseases due to encephalitis. The consultant saw her with direct ophthalmoscope because an indirect ophthalmoscope was not present. and prescribed 7 days of pulse corticosteroid treatments for optic nerve edema. After this treatment, she lost vision in both eyes and was referred with bilateral acute viral retinitis and retinal detachment. Unfortunately, this was no help for this patient. So just to note to younger doctors, when they go to consultations, always try to see as far periphery as you can. And if not sure, do not give pulse corticosteroid treatment. Then the second fault is giving corticosteroids before the diagnostic immunological assays are done, because it will result in a negative outcome. For example, when you do a Mantoux skin test, you can get a false negative test. However, systemic steroids will not interfere with quantiferon TB goal testing, so you can do that even when patient is immunosuppressed. Also, if you want to test for antinuclear antibodies, antiphospholipid antibodies, antineutrophil cytoplasmic antibodies, or any other immunology, you first have to take the test and then give, of course, therapy. And also in sarcoidosis, angiotensin converting enzyme or soluble interleukin-2 receptor can be lower after treatment. So you have to do test before. Then the next fault is giving systemic steroids as first-line medications without fully assessing the patient with fluorescein angiography and other scans, because you can miss, of course, chronic central serous chorioretinopathy and retinal macular dystrophies, which are main differentials. So this was a patient which was referred to us with optic nerve edema. As you can see in the left eye, the optic nerve margins are blurred, and suspect neuroretinitis in the left eye, but here's some fluid in the retina as well. We did the OCT and was atypical for neuroretinitis, so did fluorescein angiography and saw 2 pigment epithelial detachments in the right eye and one point of leakage showing central serous chorioretinopathy in this eye. So actually, in this case, corticosteroids are contraindicated. This is another case. Patient was referred as multifocal chorioretinitis in both eyes. And OCT was also showing a lot of fluid, retinal pigment epithelial detachment and subretinal fluid. And we did the fluorescein angiography showing that this was actually a typical pattern of hyperfluorescence for chronic central serous chorioretinopathy with this of normal looking, and we also approved CNV in the right eye, choroidal neovascularization. So the next fault for systemic treatment would be not considering the typical causes of uveitis and giving corticosteroids very long anyway, and this includes primary intraocular lymphoma and uveal metastasis. So the patient with a typical posterior uveitis that is not, it can initially respond to corticosteroids, but later on does not, is highly suspect for those conditions, so those masquerade syndromes. So this patient was referred as multifocal chorioretinitis, and we also did fluorescein angiography, and as you can see, those lesions are quite untypical for any uveitis. So after long and extensive examination, pathophysiological diagnosis was primary intraocular lymphoma. There is usually a delay in diagnosis and treatment of those conditions, at least 6 months or more, because of atypical presentation. The next fault would be not taking into consideration patient's systemic conditions and not monitoring those regularly. As was mentioned previously before, diabetes mellitus, hypertension, gastric ulcer, osteoporosis, psychiatric disorders, those patients have to be closely monitored if you decide to give them corticosteroids. Then not considering interactions. Again, it was mentioned. So some medications can increase the concentration of steroids, for example, due to increased bonding to plasma proteins and reduced elimination, like antibiotics, which we give, erythromycin, ketoconazole, anti-mycotic. Then due to reduced vitamin elimination via kidneys, like with cyclosporin A, or due to reduced metabolism, for example, isoniazid for TB or non-steroidal anti-inflammatory medications. Other medications can decrease the concentrations of steroids due to reduced GI absorption, like antacids, or due to increased activity of microsomal liver enzymes, like rifampin. The next fault would be giving systemic corticosteroids for chronic autoimmune conditions for too long and causing the systemic side effects. And those were mentioned, like Vokoyanagi-Harada syndrome, sympathetic ophthalmia, Vkh disease, granulomatosis with polyangiitis, with necrotizing scleritis and other vision-threatening side ocular complications. Then white-dot syndromes like birdshot choroiditis, serpiginous choroiditis, sarcoidosis, any chronic progressive non-infectious infectious uveitis. Systemic steroids, usually used as a monotherapy, are insufficient to achieve control of intraocular inflammation. And in those cases, quite early introduction of second line of medications, which is immunosuppression, is needed. And the final point is not giving steroids aggressively enough as the first line treatment for patients who need it. For example, presenting with sympathetic ophthalmia, Vkh syndrome, Behçet's, granulomatosis with polyangiitis, and serpiginous choroiditis. So this is a patient who was referred after with severe loss of vision that lasted for 2 weeks, and clinical examination was typical for Vkh syndrome with fluorescein angiography and OCT. After post-corticosteroid treatment, the remission was achieved and was very prolonged with completely normal findings in the OCT. And this was due to very aggressive treatment. If we were not aggressive enough, it could go to chronic stage. So the main faults with local corticostrate treatment include topical and subtenon or intravitreal applications. For topical, those are giving topical corticosteroids too frequently, too long, giving only topical steroids for anterior uveitis in cases who have some other problems, and for subtenon, giving very potent long-acting local corticosteroids for cases of infectious uveitis, giving subtenon corticosteroid injections for scleritis, giving subtenon corticosteroids injections too frequently and causing glaucoma, and injecting intravitreal corticosteroid implants in aphakic eyes. So this is a patient. Of course, if you give to a young child with a juvenile idiopathic arthritis and uveitis, topical corticosteroids too long or too frequently, more than 2 eye drops per day, it will develop such a posterior subcapsular opacity or cataract, but also any other non-infectious anterior uveitis will have the same course. Also, any non-infectious intermediate posterior or panuveitis patient who were treated for too long with topical steroids will have the same complication, but will not achieve adequate concentration of the medication in the posterior segment. So topical eye drops can be used only to treat only this spillover anterior uveitis in those patients with posterior or panuveitis, and in small amounts. Then giving topical corticosteroids without mydriatics for anterior uveitis. Our patients do not like mydriatics because, of course, they are very young. They need the vision for near vision, and also they don't like very light areas. So mydriasis is not very pleasant for them, but they need it because otherwise they develop posterior synechiae. Or if a patient has herpetic anterior uveitis, you have to cover with antivirals, or otherwise you will have a poor outcome. The next is giving very potent long-acting local corticosteroids, subtenon or intravitreal injections for any posterior uveitis, even when covered for primary infectious causes, because those very potent long-acting medications have a very long half period of life and can reactivate the infection. So this goes for viral retinitis patients, syphilis, toxoplasmosis, or fungal infections. So this would flare up the infection, but exceptions do exist, but we need high caution. Special problem is cystoid macular edema in patients with infectious uveitis, which really need a close monitoring. So this is a patient who was referred due to flare of uveitis after intravitreal 3-amcinolone injection. In the nasal upper part, there was a scar, and of course, ocular toxoplasmosis was confirmed. And despite aggressive systemic and later intravitreal antibiotics, retinal detachment occurred. So due to very potent, I think that he even got two times intravitreal 3-amcinolone, so it was inevitable consequence. On the other hand, we have another example of a patient treated for congenital ocular toxoplasmosis 10 years ago. She had a small relapse in the better right eye. The left eye was amblyopic, and she was followed next year with, again, small relapse, and then lost to follow-up for 9 years. After that, she showed up with a large scar in the posterior segment and a new lesion active, and was referred after subtenon 3-amcinolone injection and given systemic antibiotics. She was covered with 3 antibiotics for 6 weeks and added after that 2 antibiotics for 2 more, and then given Bactrim every other day for a prolonged period. And now this is what it looks like. So it was we managed to save this case. So exception to this rule are ocular toxocariasis and ocular TB. So this is a patient which was referred after treatment with subtenon triamcinolone for vitreal opacities in intermediate uveitis, as was thought to be due to those opacities in the vitreous. However, after examination, Toxocara canis larva was seen in pars plana at 11 o'clock and also was documented in serology. The patient received antiparasitic medications and was doing very well because in this case, the worm is usually dead and the inflammation is just consequence of these particles of larva just in the eye. So exception to this rule again are ocular TB. So you can use a little bit of triamcinolone for ocular toxocariasis. So exception for ocular TB, there are some case series of patients treated with Dexamethasone Implants for TB, cystic macular edema, vitritis, intermediate uveitis, and multifocal serpiginoid choroiditis with potentially good outcomes and fairly long follow-up. So this gives a new hope. However, those are endemic areas, and probably we need more data on this topic. Usually patients were covered with anti-TB medications as well. The next fault would be giving subtenon corticosteroid injections for scleritis, especially necrotizing or infectious, because it can cause scleral melting or necrosis. However, some studies that mentioned before found that this method could be alternative to systemic steroids for non-necrotizing, non-infectious scleritis. And this is a multi-center study of 53 patients with no scleral melting or necrosis. So you have to be very wise when choosing your patients. And finally, injecting intravitreal corticosteroid implants in aphakic eyes or pseudophakic eyes with posterior capsule defect. Of course, the implant can move into the anterior chamber, and also many series were documented. This is one of the largest with 15 patients with migration in the AC. So this is contraindicated. And in conclusion, when in doubt how to treat a patient, it is better to wait for a day to get additional clinical investigations than to give corticosteroids right away and flare up the infectious uveitis or central serous chorioretinopathy. Corticosteroids may be a good additional anti-inflammatory treatment for infectious uveitis when given in moderation and after a coverage with antimicrobial agents. In cases of severe non-infectious uveitis, systemic corticosteroids can achieve quick control of inflammation, but are not good long-term solutions, so second line of medication is needed, that is immunosuppressives. So when properly used, the majority of corticosteroid side effects and treatment mistakes can be avoided. I would like to thank you, and this is our hospital in Belgrade and my hometown. Thank you.
Well, thanks very much, Alexander, and thanks very much to all of you. That leaves a little bit time for some controversies. Let me ask all of you about your opinion about, probably the first is, we've heard that from different people, the maximum dosage of corticosteroids. Well, we are not talking about Japan, which has, I think, a limit of 30 or 20 milligrams of prednisolone. But how would you treat a patient who has a body weight of 120 to 150 kilograms? Would you limit that to, Aniruta mentioned, I think 70 would be the worst he goes up. What is your opinion? It's about all of you, please.
May I start, Manfred?
Sure. So
first of all, I'm fortunate that most of my patients are not weighing 120 kilos. And to be honest, I think that maybe I saw very few patients like this. But in these cases, I may start with 80 milligrams prednisone.
As a maximum.
Yeah.
Fernando, about US, I think you have a lot of overweight people there.
We do, unfortunately, and I'm a little bit more conservative. I think that my maximum dose would be 60. I'm afraid about that above 60 milligrams per day, I may be immunosuppressing them. So I agree with Annie that 60, 70 is like the threshold. So I'm afraid going above that.
Do you see any problems regarding the quick response in such patients? With, the 60 milligrams, they just have 0.5 milligrams of kilogram body weight, yes.
Right.
But the distribution may be different. I think that's a problem.
No, you're right. If I'm concerned, Manfred, no, it's okay. If I'm concerned in terms of the activity of the disease, I start them on IV therapy. So 3 days, 1 gram IV methylprednisolone. So that would be a good start, induction dose, and then I can go to 60 oral. That would be the best if I see a lot of activity.
Aniruddha,
I just want to make a point that if you feel that it's an acute disease and the patient is heavy, one of the options is actually you could use a pulse dose of steroid, IV. That could be a safer option compared to more than 60 milligrams of oral. So that's one option. You could go for a pulse dose. That's much safer.
Jean, do you see such patients?
You mean obese patient?
Yeah.
Well, we do, but I agree. I don't like heavy doses of the systemic prednisone. And usually when I have the patients with a very acute uveitis, I will give the pulse therapy. I give a gram of solumedrol once a day for 3 days, and then I keep them on a low dose corticosteroid. I rarely go over 80 milligrams, and I taper quickly while I introduce immunosuppressive therapy if indicated. So your question, I believe, was should we increase the dose of cortico systemic prednisone in a patient that have or that the patient is obese? My answer is no. I think that we should go with the lean mass of the muscles rather than, it's not because the patient has more fatty tissue that we should increase the dose. And I certainly agree that IV solumedrol is a better option if you really need to treat the patient acutely very hard than a huge dose of the prednisone.
Great. So Manisha, any experience with that?
I would agree that if I have a heavy patient to treat, I would agree with Anirudh that probably I'll start with the pulse therapy. But the oral steroid dose, I go up to 80 also at times.
Alexandra, similar?
Yes, similar. We sometimes give 80, but quickly reduce.
Great. So I think there's...
Can I ask?
Yeah, sure.
Can I a practical question for the panel? I have learned so much today. Wonderful talks, everyone. And one thing that I have some difficulties in clinic when you have 10 minutes or 15 minutes to see a patient in the US, I don't know how it is in other places, is that the question comes, okay, you're going to give me corticosteroids. What are the side effects of corticosteroids? Then I give them the short answer with very few, telling them that this is not inclusive and there are a lot of complications or side effects that could be associated to steroids. And then please follow with your primary care physician and we have to work together. But do you have an easy phrase that you use with your patients? I'm curious about what to tell the patients to warn them about the side effects of steroids in a few seconds so that we don't spend another 10 minutes with the patients discussing about side effects.
Well, I was for a long time, nearly 20 years ahead of department of our patients, uveitis patients. And at that time, we produced various small journals for these people in 3 languages, German, English, and French, together with Barambo Dagui and John Forrester. And I think in such patients who are really interested what's going on in these things, probably they have to read a little bit about these side effects. We just distributed these journals and I think they were very helpful. So I think we should probably reactivate them. We still have a lot of these examples, even in English. That's number 1. Number 2, I think there's hardly any drug where you have to explain so much as with steroids. So classically, even immunosuppressive drugs, it's much easier because people are aware of the side effects of steroids typically, and it's much easier. And I think it takes time. So in a normal situation, when people still think they give the impression they need some time, they have to ask some question. It's always good to have them not alone, to have them with some participants. Children always come with their parents, that's easy. But if two people are there, one is a patient, one is a guide, that's fine. Then I probably offer them to go out for a few minutes, let's say 20 minutes, and then come in with new questions. I think this is very important. And there are, of course, a few things which you always have to discuss, like weight increase, psychological situations, I think, something like that. And I always mention that this is a limited thing, that we are not planning to have steroids in a difficult dosage for the next months, let's say 2 or 3 months. That's very important, I think. And that's something which should be a message actually to all participants. Don't use steroids that long. So the expert in uveitis is someone who may start with steroids like everyone who sees these patients probably once a year, but then to switch very, very quickly and effectively to the adequate next drug. Extremely important, and to work with these drugs, then it's really fine. And most of these patients will really understand in this situation what's going on. Let me, before we stop now, go to one more point, which is, I think, very, very, very important and leads to a lot of problems. Until years ago, it was simply to divide uveitis in infectious uveitis and non-infectious uveitis. If you go to the program of the next IUSG meeting in Utrecht, end of August, you will find all these things on our website. We want to point out in these two different entities, in infectious uveitis, the immune component, and in immune-mediated diseases, probably infectious components. I think that's very, very important. Coming back to steroids, the point is, can you give a short comment about the role of steroids in infectious uveitis? Can we start probably with Manisha? And I think for tuberculosis, this is definitely established. You cannot or hardly actually manage a ocular tuberculosis without any steroids.
So I remember a few years back, the concept used to be that you start anti-tubercular medicines and then subsequently 2 weeks later start steroids. But I think over the years, we have all realized that it's extremely important to start steroids along with anti-tubercular medications because the inflammation associated with it is equally destructive. So now what we are all practicing is that we are simultaneously starting anti-tubercular medicines along with steroids. Having said that, another thing that we often keep in mind is that rifampicin, which forms a part of anti-tubercular medication, actually increases the metabolism of endogenous steroids. And therefore, in these patients, rather than starting a lower dose of steroids, which often we would, thinking that it's an infectious etiology, here we would actually use something like a 2 milligram per kg body weight. And I think that's extremely important in the initial phase if we want to avoid the damage secondary to the extreme amount of inflammation that we have in these patients.
Aniruta, do you have to add something in this regard?
No, I think, yeah, my thoughts match the same. I think in TB, it's well established, the role of steroids. I think the question mostly comes when you talk about viral uveitis and viral posterior uveitis on, and when you have CMV retinitis, whether or not to use concomitant steroids. And for me, I usually avoid in patients of CMV, and in AN, I usually do it only if it is a non-HIV, an immunocompetent person, only in those individuals at a very low dose. But I'd like to hear thoughts from you all.
Fernando?
I use it in some situations. Of course, the diagnosis of infectious uveitis has to be established. What is the organism? And then start treatment for that organism. And 48 hours later, I can add steroids if things are, there is a lot of inflammation. Like Manisha said, the inflammation is what is going to cause the damage, because we're treating already the infection with the antibiotics or antifungals, or antifungals, no, antibiotics. Because with fungal diseases, obviously, we want to know if this is fungal, because we're not going to treat with the steroids. So that would be a contraindication. I wouldn't use it. Examples are toxoplasmosis. So if there is a lot of inflammation after starting anti-toxoplasma therapy, I add steroids. And for acute retinal necrosis, I think it's important to add steroids after you start antiviral therapy, because the amount of inflammation, the development of PVR will lead to retinal detachment, and we want to try to avoid that. So those are two big examples, and there are others.
But I think you all agree, one second, you all agree that number one, that you have to know the diagnosis. So this is not a suggestion to use steroids for everything where you are not aware of the diagnosis. You should differentiate, is it an infectious one or non-infectious? But infectious does not tell you no steroids. That's number one. Number two is, I think you all agree that you would be careful with intravitreal injections or implants. Yes. Especially in toxoplasmosis, I think, yes. That has to do with the half-life of the steroids and the other drugs. I think this is very, very important. And I think whenever you use steroids in such situations, coming to the easiest thing, hepatic uveitis or hepatic diseases, keratitis, you always have to monitor these people very closely. Yeah. Alexandra?
I just wanted to say, for acute retinal necrosis, they can also have optic neuritis associated, and optic nerve edema and inflammation. So they need steroids for that as well, because after final damage to optic nerve, you lose vision. So.
Yeah. Well, similar for HSV, anterior uveitis or keratitis, if they go up with pressure, this needs steroids. Yeah, it's a T cell effect and not directly in effect of HSV. Zohar, any comments?
I agree with all of you, and mainly with the fact that we should not use intravitreal injections in such cases.
Yeah.
Because we can always, stop, treatments with the oral corticosteroids. But if we inject into the eye, this is another issue. We're in a big problem.
Yeah, I think so too. Jean?
Can I ask a question? I'm sorry.
Jean, to finish this.
Well, the question is, shall we give corticosteroid in infectious disease? I like to say that medicine is 50% common sense. So, we could in many cases. One exception is toxoplasmosis, as other people said. I think that's a big no-no to give periocular or even worse, intraocular corticosteroid injection. You could certainly give a bit of a PO corticosteroid. For the viral diseases, you have to be extremely cautious. If the patient is well covered by antiviral, let's take CMV retinitis as an example. If the patient is well covered for CMV retinitis and you have optic neuritis or CME associated with CMV retinitis, then it's reasonable to give corticosteroid in those patients. But again, common sense. I agree also that depo-steroid are a dangerous tool. If you're not sure, better to give a PO, and that you can stop. TB, we see a lot of TB in Canada. Somehow we have people from other countries coming with TB, sometimes with 5 different drugs to treat the TB. We see TB in our own indigenous population. And yes, we do use corticosteroid in those patients as well. Yeah.
Early, yes? Early as suggested by Manisha?
Early, yes. Often early, yes.
I think that's really what we've learned tremendously. Yes. What about syphilis? Would you add probably topical or systemic steroids in these cases?
Are you asking me, Manfred?
Well, I have all of you. What's your opinion?
Syphilis is always a double-edged sword. I'll be more cautious with syphilis than usually in my experience. Syphilis goes away quickly with the antibiotic. One thing that we've learned with syphilis, especially in the AIDS population, we always thought that in the past, when I was a medical student, we saw a lot of patients that received bismuth injection in the buttock. And when we asked the patients, were you treated for syphilis? And we took X-ray of the buttock, and we saw the bismuth injection. We saw those guys didn't know what they were talking about, bismuth injection for syphilis. And then, after the Second World War, we had the sulfa, and then people said, oh, the sulfa will cure syphilis. And then came penicillin and came ceftriaxone, and every single generation said they're better than the other one, the previous generation, and then we will cure syphilis. Well, and I think syphilis cannot be cured. Syphilis is a disease that you have to follow very, very closely. You have to repeat the non-specific test, and if the titers increase, you have to retreat the patient again. So I'm very cautious with corticosteroid and syphilis because it may mask the recurrence of the infectious syphilitic uveitis. So I'd rather follow the patient, and if I see an increased inflammation, I will rather retreat the patients with antibiotics than giving corticosteroid. I'm not saying they're not needed in some cases, but always keeping in mind that at the moment, I don't think we can cure syphilis. And if you see reactivation of inflammation, it's probably a new infection, an ongoing infection with the treponema.
Mm-hmm. Oh, for sure, you need first antibiotics or antivirus, that's sure. Okay, so any more additional points to this?
I wanted to ask a question to Manisha. She showed, and I've been fascinated with the results of intravitreal bevacizumab for the granulomas in TB, and you mentioned the VEGF levels elevated in these cases. Is that the case as well for other forms of TB, including vasculitis and TB? Can you treat with intravitreal bevacizumab or not, in your experience? And maybe Annie also knows about it.
So right now, actually, we've just done a study on TB granulomas. And there we found that the VEGF levels were extremely high. They're about in the range of 1,000 to 1,500 picograms per ml in comparison to an AMD CNVM, where they're in the range of about 100 to 200. So TB granulomas, surely they are like, a huge reservoir of VEGF. And in the past, we've actually lost eyes where they became painful blind eyes requiring a removal when we were just treating them with, once a month anti-VEGF along with ATT and steroids. So now with our experience, we are actually treating these patients with a weekly injection of bevacizumab and moxifloxacin. And these patients have not required more than 2 to 3 injections and have shown a beautiful regression of the entire choroidal granuloma. Of course, as I showed in my patient, and that's another indication of steroid in TB, is a paradoxical reaction sometimes we do get after having started these patients for 2 to 3 weeks on ATT. And that, of course, needs something like an IVMP or a stepping up of the oral steroids.
But then you don't use it in other forms of TB?
Not as yet, but yes, we are conducting a study where now we are including the other phenotypes and seeing how is their response and what are the VEGF levels in other phenotypes as well.
Thank you. Amazing. Wonderful.
Okay, so thanks to all of you for wonderful presentations, for great discussions. Please stay online. As you can see, there are 10 questions and answers. They're waiting for your answer. Probably you can help me to answer these things. For all participants, thanks very much for participating. I hope you learned also, as I always do with these webinars, something. You know that we have a break now of 2 months. The reason for this is holiday season in summertime. And finally, also the coming ISO meeting in Utrecht in the Netherlands, end of August. You're more than welcome to join us personally or virtually, just as you want. And we will meet again in beginning of September. Have a good time. It was nice to entertain you. Thanks.
Thank you so much for the invitation.
Thank you.
So I need your help, please. Have a look for the answers, question and answers here. Probably you can go through them. So there's the first one regarding bridging therapy. That's a good one for Aniruddha.
So the first one is, while you're switching immunosuppression, bridge therapy, how much is recommended? So I think it's a simple answer.
No, can you answer these things?
Yeah,
simply?
yeah, I'm on it. Yeah, I'm typing the answer. I think that's easier.
Yeah, I did answer one of them as well. So yeah, we're working on it.
Okay.
There is a question about role of steroids in postoperative or any postoperative, I think, endophthalmitis. I think I saw that.
Yeah, the problem with postoperative endophthalmitis is sometimes corticosteroids are needed because even though you cure, somehow decrease the bacterial load, those bacteria or the antigen from the bacteria are acting like an adjuvant. And you still have this ongoing sterile inflammation that can occur in a postoperative endophthalmitis. So yeah, sometimes corticosteroids are needed and sometimes long term. And when you stop them, the inflammation is coming back. So it doesn't necessarily mean that the infection is still going on, but there's a kind of adjuvant type reaction that can occur following the treatment of postoperative endophthalmitis.
I totally agree. Once you get the results from the lab and confirm that this is bacterial ISTAR and steroids 48 hours later, it's very useful.
Okay. Done. Thanks so much.
Thank you.
Thank
Have
you.
a beautiful weekend.
Bye.
Thank
Bye.
you. Have a nice day.
Thank you. See you in Utrecht.
Yes,
too, everyone.
please.
See you.
Good
Bye.
to see you all. See you all. Bye-bye.
Bye-bye. Take care. Bye-bye.
Bye.